Hello and welcome to today's webinar, Caring for Older Adults with Complex Needs in the COVID-19 Pandemic, Lessons from PACE Innovations, hosted by the Better Care Playbook and the National PACE Association, through support from the 7 Foundation Collaborative and West Health Policy Center. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, and welcome everybody to today's webinar. I'd like to again thank the 7 Foundation Collaborative and the West Health Policy Center for generously supporting today's webinar. And today we're excited to explore how the Program of All-Inclusive Care for the Elderly, or PACE, which is an evidence-based model of care for older adults who meet a nursing home level of care, has been adapted how they deliver services during the COVID-19 pandemic to care for high-need older adults, as well as lessons from these innovations for healthcare stakeholders who are working to improve care for older adults with complex needs. Next slide. On today's webinar, after some brief introductory remarks, leaders from the National PACE Association will describe the PACE program as well as the needs of PACE participants. Next, we'll hear from leaders at 3 different PACE organizations who will each describe how their organization has implemented new approaches around chronic care management, addressing social determinants of health, including social isolation and loneliness, and repurposing the PACE Day Center setting. Then we'll hear from the National PACE Association on policy considerations for supporting access to community-based options for older adults with complex needs. And after we hear from these presenters, a national expert in integrated care for older adults will reflect on the implications of these innovations for healthcare stakeholders who are working to improve care for this population. And then our presenters will answer questions submitted by all of you during the webinar. And again, if you have a question you would like our presenters to answer, please submit it anytime by clicking on the Q&A icon at the bottom of your screen. Next slide. So as you'll see here, we have a wonderful lineup of speakers today, and I'll fully introduce each one before their respective presentation. Next slide. And I'll first provide just a brief overview of the Better Care Playbook. The Playbook is an online resource center for evidence-based and promising practices for people with complex health and social needs. And so the Playbook summarizes the latest research, it shares actionable implementation guidance, and it provides first-person perspectives on the work of improving care for high-need, high-cost populations. And the Playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading healthcare foundations, which are Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And again, the Playbook's website is www.bettercareplaybook.org. Next slide. And as most PACE participants are dually eligible for Medicare and Medicaid, I'll provide some context over these next few slides on the importance of improving how care is delivered for dually eligible individuals. And this group is a high-need population. The statistics on this slide show the significant percentages of dually eligible individuals that have multiple chronic conditions, that have behavioral health conditions, and that need long-term services and supports. And I'll note that dually eligible individuals also account for disproportionate spending in both Medicare and Medicaid. And while this population has complex needs and would benefit from receiving coordinated care, they're at high risk of receiving fragmented care. Integrated care models such as PACE work to align how Medicare and Medicaid services are delivered, paid for, and administered in order to improve outcomes, yet only 10% of dually eligible individuals across the country are currently receiving integrated care. Next slide. And our speakers will provide more background on PACE and who it serves and how it delivers integrated care. And I'll highlight here some of the studies and evaluations of the PACE program that have shown evidence of positive outcomes, and much of this evidence is summarized and linked to on the playbook. Notably, there is evidence that participating in PACE is associated with lower inpatient hospital use, and that average length of stay is shorter for PACE participants who are hospitalized. There's also evidence of improved quality of care, high levels of participant satisfaction, and improved care coordination for PACE participants. And then I'll also note a study found a substantially lower risk of nursing facility admission, especially for people with dementia, which shows the effectiveness of the PACE program at enabling high-need individuals to continue to live in community settings. Next slide. And populations who are at highest risk due to COVID-19, such as those with multiple chronic conditions or frail older adults, are disproportionately represented by dually eligible individuals. And we saw this in data just recently released by the Centers for Medicare and Medicaid Services, showing that dually eligible individuals are over 4 times as likely as Medicare-only beneficiaries to be diagnosed and to be hospitalized with COVID-19. And among all racial groups, Black dually eligible individuals have the highest rates of COVID cases and hospitalizations. The chart at the bottom of this slide shows the breakdown in cases by race. The blue columns represent Medicare-only beneficiaries, and the yellow columns represent dually eligible individuals. And many of our speakers today will be addressing how PACE programs are positioned to address these racial disparities and to address the needs of vulnerable older adults. Next slide. And next we will hear from Mia Pfeiffer, Vice President of Quality, and Chris Van Reenen, Vice President of Regulatory Affairs from the National PACE Association.
I'm sorry. Great. Hello, everyone. Thank you, Logan. And to all of you on today's webinar for your interest in PACE. The next several slides, and I'll ask Travis to please advance the slides. The next several slides provide a broad overview of the PACE model. Initially, PACE was a Medicare and Medicaid demonstration program. The program of all-inclusive care for the elderly was authorized by Congress as a Medicare provider type and voluntary state option under Medicaid in the Balanced Budget Act of 1997, now well over 20 years ago. PACE is an integrated care model and delivery system that is importantly community-based. The primary objective of PACE is to support participants' autonomy and independence in their homes and communities. 95% of PACE participants reside in the community as opposed to long-term nursing home settings where they receive a broad array of community-based care. The PACE model is comprehensive in that PACE organizations are responsible for providing their program participants a comprehensive benefit, inclusive of all Medicare and Medicaid covered services, either directly by staff or through contracts with network providers. The PACE model features a value-based capitated financing structure. Under its capitated financing arrangement, PACE organizations are fully at risk for the comprehensive benefits they are responsible to provide. And the services provided by PACE organizations are highly coordinated by PACE interdisciplinary teams who are responsible for comprehensively assessing participants' needs and developing and implementing care plans that address those needs on a 24/7 basis. Next slide, please. Who does PACE serve? We serve individuals who are 55 years of age or older and who live in our PACE organization's geographic service areas. I want to mention that PACE organizations serve both rural and urban areas, with some combining both. These service areas may be relatively small or compact in densely populated urban areas, or they may encompass multiple counties and hundreds of square miles in more rural settings. All PACE participants must meet their state's eligibility criteria for a nursing home level of care. And finally, because the primary objective of the PACE program is to keep people at home and in the community, at the time of enrollment in PACE, participants must be able to live safely in a community setting with the support of the PACE program. Once enrolled, however, PACE organizations are responsible for meeting all needs of participants, regardless of whether or not they remain in the community, or as is the case for a small PACE participants, they ultimately require nursing home care. Next slide, please. Currently, PACE is available in 31 states across the country. In some states, PACE is available statewide or nearly statewide. In others, access to PACE is more geographically limited. A total of 133 PACE organizations operate 263 PACE centers. And in addition to those 133, there are another 10 or so PACE organizations in the final stages of PACE development. And also numerous existing PACE organizations are seeking to expand either by increasing their geographic service areas or by increasing the number of PACE centers in which they provide care. Next slide, please. These 133 PACE organizations currently enroll a total of approximately 54,000 PACE participants. Enrollment in PACE organizations ranges from less than 50 among newly operational programs to more than 3,000. On average, PACE organizations enroll approximately 400 participants. And a few words about the most important of all people in this story, our PACE participants. Because all of our participants must be eligible for a nursing home level of care, they constitute a high-cost, high-need population with multiple chronic medical conditions and significant functional and/or cognitive impairments. On average, PACE participants have 6 chronic conditions, and nearly half of all participants have a diagnosis of dementia. The average age of PACE participants is 76, and about 15% of our participants fall between the ages of 55 and 64, so not all are elderly. Nearly 70% of PACE participants are women, and as Logan pointed out earlier, 90% are dually eligible for both Medicare and Medicaid. Next slide, please. So with respect to PACE services, again, PACE organizations are responsible for providing all needed Medicare and Medicaid covered services. And those are inclusive of medical care, behavioral health care, and long-term services and supports. In addition to Medicare and Medicaid covered services, PACE organizations, PACE interdisciplinary teams also have the flexibility to provide other services determined necessary to improve or maintain a participant's health status. An example of this might be for a PACE organization to pay for and install an air conditioner for a participant with a respiratory illness. The interdisciplinary team has flexibility to develop care plans that address not only healthcare needs, but also social determinants of health. In PACE, it is possible to respond to the needs of the whole person, and by doing so, utilize resources more effectively to the benefit of participants, providers, and payers. And with that, I'm going to turn the presentation over to my colleague, Mia Pfeiffer.
Thank you, Chris. Although not inclusive of all items and services provided by PACE organizations, this slide illustrates the breadth of services provided by PACE. Many of these services are provided directly by PACE organization staff, which includes primary care providers, nurses, social workers, dietitians, and many more. Services not provided directly by PACE staff are provided by contracted providers. Many of these services are provided in the PACE Center, which is a setting unique to PACE in that it combines a primary care clinic with a day center. At the PACE Center, participants receive primary medical and nursing care, social work services, as well as rehabilitation therapies. It is also the setting for meals and a wide range of day center activities and opportunities for socialization. The PACE Center, along with participants' homes, are primary settings for the provision of care. When participants are not in the center, if necessary, services are provided to them in their homes. Typically, this would involve personal care services to assist participants with tasks such as bathing and dressing, as well as homemaker services. Next slide, please. The PACE interdisciplinary team is the hallmark of the PACE model. The team is comprised of 11 disciplines who collectively develop and implement individualized, participant-centered care plans. These care plans are informed by comprehensive assessments that are conducted upon enrollment and at a regular interval thereafter, and in response to significant changes in a participant's health status. Rather than having an individual care manager that implements and monitors the care plan, this is done by the PACE interdisciplinary team collectively. Although there is some variation across programs in terms of specific processes, teams typically meet daily to address the issues that require close monitoring, such as the status of a hospitalized participant or a participant who may need immediate assistance with housing. Interdisciplinary teams also meet on a weekly basis in assessment and care planning meetings to develop and update care plans as needed and in response to regulatory requirements. Next slide, please. With respect to financing for PACE, PACE organizations receive monthly capitation payments for enrollees based on their eligibility for Medicare and/or Medicaid. These capitation amounts are payments in full with no additional payment from participants in the form of deductibles or other cost-sharing amounts. Medicare capitation payments are calculated by the Centers for Medicare and Medicaid Services using a model similar to that used for Medicare Advantage plans. Payments are individually risk-adjusted based on each participant's demographic and diagnostic characteristics. The average Medicare capitation rate paid to PACE organizations as of January 2020 was approximately $2,800. This rate is inclusive of a payment for all Medicare Part A and Part B services. PACE organizations receive an additional monthly capitation amount for Part D prescription drugs. Medicaid capitation rates paid to PACE organizations are derived by the state and intended to provide states cost sharing relative to what they would otherwise pay for a comparable population outside of PACE. Distinct payment amounts are paid by Medicaid for dual eligible participants and those who have Medicaid coverage only. For Medicaid-only participants, who comprise just under 10% of PACE enrollees, Medicaid is the sole payer, and a higher per member per month rate is paid to account for the fact that Medicaid is paying not only for long-term services and supports, but also for services that are paid for by Medicare for Medicare beneficiaries. The mean Medicaid per member per month rate of $39.81 shown on this slide is for dual eligible beneficiaries. Lastly, a small proportion of PACE participants, approximately 1%, are eligible for Medicare only. These individuals pay a premium to the PACE organization that is equivalent to the state's per member per month payment. On average, this would be approximately $4,000 per member per month for comprehensive long-term services and support care, inclusive of nursing home care, should that be necessary. Next slide, please. To tee up the next several presentations, which will feature innovations implemented by PACE organizations in response to COVID-19 public health emergency, I'd like to highlight significant adaptations that PACE organizations have implemented. First of all, a largely center-based model was transformed virtually overnight into a largely home-based model. To prevent the spread of infection and to ensure to the greatest extent possible the safety of participants and staff, PACE centers and to a large extent their primary care clinics were closed. The provision of care moved from these centers into participants' homes. The extent to which this happened varied somewhat across programs depending upon the prevalence of COVID-19 in their communities, but this was the situation facing the majority of PACE organizations. While there was no option to providing in-person care in the home for some of the services, such as personal care services, PACE organizations expanded their use of telehealth to extend their capacity and minimize in-person contacts. Telehealth options are used to varying degrees for ongoing assessments, monitoring, and when possible, care delivery. The workforce in PACE, largely center-based, was deployed into the community. This deployment involved all members of the interdisciplinary team and involved providers delivering services that would, under normal circumstances, be provided in the PACE Center. In person in participants' homes, this also required protocols to ensure that ongoing effective and communication amongst the interdisciplinary team members so that assessment, care planning, and care coordination continue. To address concerns of social isolation, remote technology has also been used to address participants' social needs. And lastly, many PACE organizations have used their PACE centers and transportation resources in new and innovative ways. Several PACE organizations repurpose their centers to provide overnight care, in virtually all cases, transportation resources that would otherwise be utilized to transport participants to and from the PACE Center have been used to transport need items, including meals, durable medical equipment, medications, and more to participants in their homes. You will hear much more about these adaptations in the following presentations. Next slide, please. Finally, beginning in April, the National PACE Association initiated an effort to collect data from its PACE organization members on the incidence of infection among PACE participants and numbers of participant deaths due to COVID-19. On this slide, we present the data available to us at this time. Please note that this is not comprehensive data and that it has been reported by only 100 of 133 PACE organizations. Also, PACE organizations reporting data have not been entirely consistent with respect to the frequency of reporting. NPA's analysis of the PACE organization data as of June 14th suggests that approximately 4% of participants enrolled in PACE organizations reporting data have tested positive for COVID-19. Furthermore, 1% of participants enrolled in these 100 programs have died as a result of the virus. Our analysis indicates that rates of infection and death are greatest amongst those organizations located in states hit hardest by the pandemic, including New York and Massachusetts, for example. We are also seeing, based on more limited data, that it appears that the majority of COVID-19 related deaths are likely occurring amongst PACE organizations who reside in skilled nursing facilities and other congregate living settings, such as assisted living facilities. We are working to improve the representativeness of the data we are collecting and to understand its implication for PACE moving forward. More to follow on this. Now I'd like to turn it back to Logan so that she can introduce the next presenter. Thank you for your time and consideration.
Great, thank you so much, Mia and Chris. Next, we will hear from 3 PACE leaders on how their organizations have developed and implemented innovative approaches to address the needs of PACE participants during the COVID-19 pandemic. Next slide. First, we will hear from Marianne Ratcliffe, Executive Director of Piedmont Health Senior Care. Oh, Marianne, I think you might be muted.
Sorry. Thank you, Logan, and thank you everyone for joining this webinar. I'll give a brief background on our organization. The organization is Piedmont Health Services Incorporated. It's been around 50 years. It started out as a federally qualified health center, and during the last 5 decades expanded to include 10 community health centers and 2 PACE centers. We are in a mix of a rural and urban geographic service area. We opened our first PACE site in 2008 and our second one in 2014. And currently we serve 325 frail, financially needy seniors. We do not have any who are without Medicaid. We have an average of 8 chronic conditions and 12 medications at the time of enrollment. Largely, you can see on my slide here, chronic heart disease, chronic lung disease, renal disease, diabetes are significant areas for our care planning at our program. Next slide, please. So as Mia and Chris indicated, PACE is fully responsible for the outcomes of our participants. The beauty of that, the capitated structure aligns the quality and financial incentives with the provider. We are responsible for the full spectrum of care from preventive care to end-of-life care. Our participants are highly vulnerable for serious complications from COVID-19. And our adult day center, or our PACE center, is the hub of activity. So we were a center-based program. It's a congregate setting that has been determined to be at high risk for exposure to COVID-19. So the last place we would want to send high-risk individuals for COVID-19. PACE also, some of our challenges in meeting our participants' needs under COVID is PACE has always been high touch, relatively low tech. PACE is not about the most aggressive, it's about meeting care, it's about meeting the needs of the individuals and honoring their wishes as they age in place. And COVID really forced us to turn that around. To some extent, it's relative what high tech is, but for our program, it certainly was. It moved from, as Mia said and Chris, center-based services to largely home-based services and some virtual or remote services. We had to adjust our care management, particularly for those with chronic conditions, as far as primary care, behavioral health, and functional supports accordingly. Next slide, please. I would say that I'm a spokesperson for PACE. I'm not necessarily, for those PACE programs on the call, I know they will recognize many similar approaches. We all had to pivot very quickly in identifying new service delivery platforms. So we started out by assessing our risk or risk stratification of our membership, of our participants, and identifying new means of meeting their needs in their care plans. So we have a regular review of our patients' chronic conditions and their well-being. Frequently in the past, that regular review was seeing them in the day center and just even a social worker walking by and saying, hey, how you doing? And what are you up to this weekend? Or what did you do this weekend? Our monitoring of our participants has changed drastically as a result of COVID. So we developed protocols for monitoring our high-risk participants. So for instance, those with COPD who are at risk of exacerbation or hospitalizations, those at risk for skin breakdown, or who have previously had a history of wounds, for instance. So we had different monitoring tools for those individuals that are identified as high risk. We also had previously not used telehealth. Frankly, in our program, if we needed to see them, we're pretty much just having them at the day center and monitoring them in that regard. COVID changed that. So we quickly, in March, applied for some grant dollars and purchased some equipment to allow us to better monitor our participants. We also conducted a survey, survey by phone, so low tech, just assessing what their technical ability was. So what sort of technology did they have? As far as our ability to connect with them over Zoom, for instance, or conduct other telehealth type connections with us. So we purchased things like blood pressure monitoring devices and scales and temperature readers with capacity that report to our EMR, glucometers that report to the EMR, pulse ox, Zoom tablets for our participants, internet links with, or sometimes called jet links for those who didn't have connectivity in their homes. Some of this is still in progress, not fully completed. And so it's all happened quite quickly. For individuals, so for our Zoom licenses, we had to purchase the HIPAA compliant ones. So we purchased 16 of those to make sure they were accessible to staff at all points during the day when they might be able or needing to connect with somebody. So let's see, we also were fortunate in our state, we're required to also have a home care license as a PACE program, and our governor granted a temporary waiver during the emergency response to COVID so that PACE programs in North Carolina could deploy their staff into the homes, whereas previously, if they didn't have a license, they could not do that as readily for direct patient hands-on care. So we did redeploy our staff. Our CNAs are now in the home as opposed to at the center on a regular basis, tending to personal care needs. We redeployed our drivers differently. They assisted us with screening and curbside check-in for our pharmacy. We converted a van, a 12-passenger vehicle, into a mobile exam room. Our medical director, providers, and rehab and drivers developed that vehicle. The intent of that is in some of our homes there is not good lighting, or the conditions in the home are not necessarily the best for an exam, and yet the individual might be needing an exam that we don't want to bring them into the day center in the event of a potential exposure. So that was a quick turnaround there that the staff developed creatively. Next slide, please. So now we rely more on telehealth alerts to manage chronic issues. In addition to televideo, we do evaluations of acute or episodic care. Every week, every participant, whether they're high risk, low risk, or in between, they have a lengthy call from one of our staff members reviewing their systems. So everything from if they're diabetic, do they have they had any issues with their sugar? Have they been checking their sugar? If they're insulin dependent, have they been using their insulin? So any medication issues, have they fallen? Have they used their lifeline in the last week? And these are things that ideally we're talking with folks pretty much on a daily basis, but sometimes they might not disclose it unless you ask. So those are some examples of, are they low on medications? Do they have any concerns about groceries or food? How are they getting their food? How are they getting their groceries? Our hope is their response is not, I'm going out. If that is the response, we're going to be working with families or other community supports to alleviate that responsibility. Our aides are in the home, as I said. So are our PCP, primary care providers, our nursing staff, our OT, and our occupational and physical therapists. They are additional eyes and ears in the home. We do deploy our staff with full PPE in the home in an interest of protecting both staff, but mostly participants, as they are, our staff are the ones more likely to bring it to them. So our aides are really helpful in relaying what's happening at home and monitoring subtle differences that we would have otherwise identified in the day center. These various things I've noted there prompt a clinic visit with the primary care provider, or a home visit, evaluation, ER referral, or a specialty consult. So it's in this way that we are able to manage conditions, manage our patients' care across the spectrum still, though very differently. The functional supports for CCM, for chronic care management, we focus on avoiding infections, maintaining medication adherence, maintaining nutrition and intake of and other substances perhaps ingested, as with mental health issues and a time in a pandemic, these things can escalate. So that is something we bucket underneath the nutrition category. Falls, depression is a key one. So our team huddles twice a day, our interdisciplinary team. We have multiple interdisciplinary teams. For our 325, we have 8 different teams. And they coordinate care. They meet in the morning and they meet again in the afternoon, and oftentimes in between. So it's very tightly coordinated care. Next slide, please. As far as one thing I forgot to mention is with regards to depression and socialization. I think one of the biggest things we've learned in this is the importance of connectivity, of feeling loved, of knowing people care about you. Without that, depression sets in, isolation, real grief. So simple, very, very simple acts of kindness from staff, unprompted, have helped to sustain the clinical outcomes and the quality of life we would like to see in our population. So, whether they're virtual bingo games or live bingo over Facebook we've done, or virtual painting classes over Zoom, videos posted on YouTube, follow up to make sure they can access it, or they have a caregiver that can help access them. Bouquets delivered on Mother's Day, salsa, dance, Tai Chi videos, support of developing new routines, having a routine and having the mind being able to expect what's coming next for me is really important. A soft robot lapdog for a participant with dementia, simple low-tech interventions to stay connected and prevent social isolation, anxiety, and depression have been important. We will continue to evolve service delivery platforms, staffing, and allocation of resources to meet our patients' needs in the era of COVID. We will continue to evaluate the risk-benefit of attendance at the day center versus in-home care versus remote technology. And we will continue to evaluate the impact on outcomes, wanting to always balance access, quality, and mission to the PACE program. And just to generally appreciate the capitated structure, were it not for the flexibility afforded by the financing, the capitation, we would not be able to be so innovative. Thank you for listening, and I'll turn it back to Logan.
Great, thank you so much, Mary Ann. Next, we will be joined by Samantha Black, Executive Director of True PACE in Colorado.
Hi, thank you, Logan. Again, my name is Samantha Black. I am the Executive Director of True PACE out in Boulder County, Colorado. We opened about 3 years ago, March 2017. We are among the younger PACE organizations nationwide. Our current census is about 190. And we do kind of map onto other PACE organizations in terms of our own demographics. Our average age is 76. About 70% of our participants are female, 30%, yes, female, and 30% are male. We are not the most diverse PACE organization, but we are 75% white Caucasian, and then the remaining 25% are comprised of Hispanic, folks who identify African American, Asian, Native American. Most of our folks do live in their private homes. Of those private homes, 60% live alone. So that means that currently about 90% of our participants are, all of them are nursing home eligible, but about 90 of them are living at home alone, which means that just like the other PACE organizations, we're taking care of a pretty vulnerable population. We are very deeply invested in keeping them safe and healthy at home and helping them meet their health care goals. And next slide. I was asked to speak a little bit about the social determinants of health and how COVID has impacted those, and then how the PACE organizations are uniquely positioned to be able to address those in a really powerful and meaningful way for all PACE participants across the nation. So as all of you know, if you are in any sort of contact or touching the elderly population nationwide, there are key social determinants of health that have been heavily impacted and are very much of concern when it comes to our older populations. So certainly 100% of our folks have poverty and economic hardship issues that have been made worse by COVID. Affordable, safe, stable housing has become an issue for some folks. Nutrition and food security, Mary Ann alluded to this as well, around, can folks, if you are at home and you are nursing home eligible, you're probably not driving, and how are you getting your food? For us, with such a high percentage of our participants living at home alone, they were suddenly very vulnerable. Like, we had to think about those really key questions around how are we going to make sure they are getting their food? if they're not accustomed to getting out, and some of those typical supports that they have, like grocery delivery from the local grocery store, have been put on hold. Transportation was also pretty heavily, dramatically impacted for these folks. Access to preventive medical care. Everybody is able to call 911 when they need it, but what we were finding, as all of you probably were as well, is that it was the preventive medical care that was being, you know, we have a network of over 400 providers that suddenly everybody closed their doors and said, nope, not doing the routine stuff. If it's an emergency, I might be able to open my door for you, but otherwise, you know, PACE suddenly was like, we've got a lot of really vulnerable people who, you know, we want to make sure we're continuing to take care of their basic needs so that we're not deferring a lot of care till later, and now they have more complicated outcomes that we need to address. And then the one big one that I was asked to address was really the importance of social relationships and engagement, and how COVID, for all of us nationwide, but especially the elderly who are more isolated at home, COVID has the potential to have a very large, heavy negative impact for this population in particular. And so all PACE organizations felt a very strong mandate to how are we going to continue supporting folks and preventing or mitigating social isolation and loneliness through this time. Even those of us who can get out and drive and maybe step outside and see neighbors, a lot of the PACE participants, a lot of elderly across the country don't have that ability or luxury. And so suddenly it was very apparent to all of us that we needed to get as creative as we could and come up with some solutions to help people feel engaged, to help continue feeling really connected. I can say that one of the most important and unique things about PACE itself is founded in a social model. So first and foremost, it's all about how do we create that sense of community and belonging and inclusiveness for all of the older adults that we are privileged to serve. And that's really the foundation of everything we do. And then embedded in that is just exquisite medical care, exquisite rehab, and all of the therapies and everything that's needed for folks to live as optimally and healthfully as they can as they age. So next slide, please. Oh, that's the backwards. Thank you. So most of these are not anything unique to True PACE. I really want to acknowledge that and really celebrate that the PACE organizations across the country are doing fabulous work to help mitigate the impact of social isolation and loneliness for PACE older adults. But the key is really how do these folks, as Marianne had alluded to, these folks are used to coming in, having a lot of contact. We have folks who come in once a month all the way to 5 days a week, and they enjoy that sense of community and that sense of I've got a place to go and people look forward to seeing me and I matter, and I have an important something to give to my community at PACE. And so it was really interesting, like how are we going to create or continue that feeling and that sense of connection for folks? That is really what makes PACE so unique and what makes PACE really work for older adults. So we quickly pivoted, similar to Marianne's organization. She discussed this a little bit, but things like daily staff calls. So anybody who wasn't immediately involved in the day center when we had to close it, they were suddenly making calls to our participants every day. And we're still doing that for the majority of our participants. Just that warm touch, that, hey, how you doing? We miss you. How are you hanging in? We also deployed a bunch of tablets, smartphones, and social platforms to help folks stay connected. We had already been integrating those into our services, but it was a very quick, like, wow, we need this right now. We don't have the rest of the year to drop these in. We have to get these going right away. So we are a part of a larger healthcare organization called True Community Care, and they responded very quickly to get us the tools we needed to get these devices out in the homes. We instituted weekly town halls. So PACE is very much a co-designed program with the participants and the staff, which is really fun. And so we host weekly town halls where people can call in or they can Zoom in, and they can talk with our administration and the rest of the team around how are they doing, what's working, what recommendations would they have for what could help support them or be meaningful to them as they navigate this pandemic. The participants, again, the co-design part of this, they really wanted to have a stake in this, and they wanted to have something to do as well. So boredom can be a big part of this for any of us, but for older adults who are really isolated, boredom is a key issue. So they initiated their own phone tree. They wanted to be able to talk to each other and be able to reach out to each other. And you know, talking to PACE staff is nice, and it's one thing, but it gets a little stale. It's much more interesting in some ways to be able to talk to your friends who you usually sit with at the day center. And so they started doing that. They've also been very concerned about onboarding our new participants who are not coming into PACE as PACE normally looks. And so to help land those people and help them feel a very warm welcome, we have our PACE ambassadors, who are some participants who have become phone buddies for the first 3 months with some of our PACE participants, our new enrollees, which has helped a lot. We have, similar to Marianne's organization, she talked about online socialization groups. So everything that we were doing for socialization in the day center, now we're doing those on Zoom or on smartphones, or people are calling in. However we can create access so people feel connected is critical right now. We have 2 really fun programs that have come up over the last month. One is a tri-shop program, and it's really designed, it is a thing that started in Denmark, and it's kind of spread over to the US, where there's a local organization that brings over essentially rickshaws. If you know what those are, they're bikes with couches on them, and they can push 1 or 2 people. And their whole philosophy is to get older adults out into fresh air and feeling wind in their hair and being able to have a really good conversation, going slow, looking at the blue sky and the birds and talking about flowers or kids or whatever it is. Rides that can last anywhere from 10 minutes to an hour. But we have partnered with a local organization who brings their bikes over now and does that 3 mornings a week for any participants who are here for medical appointments. They just are able to take them out for a ride. They are socially distanced. They have a plexiglass between the driver and the participant. And it's just a lovely opportunity for folks to have a good conversation in a safe way. We've also opened an adoptive grandparent program, which I'll talk a little bit about more on the next slide. If Logan, if you could advance the slides. This is a program that many PACE organizations are also integrating as well. There's a little bit more about it on the next slide. Logan, if you can advance that, thank you. A big part of any rec therapy program that works with older adults often involves intergenerational socialization, which offers a really unique way for people to not just be engaged, but feel like they're actively participating. So, and offering something back. And so we have participants as well as a group of teenagers, as well as families with younger kids who wanted to be pen pals. And so our marketing and enrollment team put together essentially an adoptive grandparent program where community members would be able to become pen pals with any of our pacers. They call them the purple pacers of True Pace. But it's just a really fun opportunity. It's obviously very safe. They're pen pals. They do phone calls. They do Zoom calls. Obviously social, as well socially distanced as you can be. But the intention is really to involve the whole community, not just PACE, but the whole community, in helping create a sense of belonging and community, as well as the PACE participants feeling like they're engaged and being able to share something back. And we just started this. It's already, I think we've got about 10 participants who are involved in this right now, 1 to 2 hours a week. They have to go, the volunteers do some screenings, but we give them activity materials and lists of ideas of things they can do. And then also we have storytelling interviews. So especially the teenagers love doing this, where they get to ask their older person or their pacer provocative questions like, tell me about your favorite memory, and tell me what's the most important thing you've learned in your life. So lots of engagement and lots of fun, but just really keeping folks like, not only are they engaged, but they're giving something, which is really an important part of this time of life. And so this is an opportunity we offer them as well. Next slide, please. Lessons learned. We've learned a lot from our participants. When I talked about that town hall, they're very active and engaged with us around what it means to be aging right now, especially at this time. And something that they've come up with and have shared with me quite a bit is that they want to be, quote, active participants, not passive recipients of care. They don't want to feel like things are happening to them. They want to be engaged in the whole process around the pandemic, around the activities they're involved in, around what works for them. So a lot of feedback back and forth, which is really powerful, and it's fun to co-design things with them right now. We have this up and coming generation that is, has always, their whole life has been engaged in national or global events. Maybe they were active in the civil rights movement. Maybe they were active during World War II, Vietnam, what have you. And they're not used to just kind of sitting back and having things happen to them. So it's important, especially for our folks who are, in the 70s, 65 to 80 range, where they're just really saying, I want to be a part of this. I don't want to just be waiting for something to happen. So they're stepping in, and with our tools, they're combating isolation with each other, which is really powerful and exciting. Another quote they come up with is, "We are venerable, not vulnerable," which really points to that intergenerational piece of, I have something to offer, and I matter, and I have learned so much, and I have something to give, whether it's to my age cohort or to the staff or to a younger adult or a family. And so they really use that phrase a lot of, we are venerable, not vulnerable. They talk about themselves being elders of our tribe, and how important that is that we deliver opportunities for them to give back and to really participate in what's happening with our community. I always like to say that the power of PACE at its most fundamental core is community. We create a sense of community and belonging in a way like no other, through integrated care, through the socialization model that we are all couched in. So the power of PACE truly starts in community, and from there, all the rest of it happens to improve outcomes and optimal outcomes for these folks. Like I said, belonging, inclusion, and contribution, those are the big key factors for folks right now. Next steps, our participants are co-designing with us a vibrancy program, which is very comprised around continued sense of community, but also education around what does it mean to age and age well? How do you do it, and how do other cultures do it, and how do we integrate that into our program? And then, similar to Marianne, we're going to be introducing a Teen Tech Volunteers program. There's a lot of older adults in our program who want to avail themselves of the telehealth models that we have and the devices we have available, but they're struggling to, they didn't grow up with a laptop in their crib like some of our folks did. So we'll be introducing a Teen Tech Volunteers program by phone and eventually in the day center to help folks with their technologies. So thank you for the time. I'm so humbled and honored to be here today. Thank you.
Great, thank you so much, Marianne. And our third and final PACE organization leader that will present today is Dr. Robert Schreiber, Medical Director of Summit ElderCare.
Good afternoon. I want to thank the National PACE Association, the West Health Policy Center, and the Seven Foundation Collaborative for this opportunity to discuss Fallon Health's PACE program in the age of COVID-19 and how we actually repurposed the day center for 24-hour care. We have just heard how a couple of PACE programs have responded to the pandemic around chronic care management and social determinants of health. Now we will give an example of innovation in practice as we discuss our approach to an alternative care center during the pandemic. Next slide, please. Summit ElderCare overview. We're the 7th largest PACE program in the country. We're the largest in New England. We have 6 PACE sites in Massachusetts, 1 in Western New York, and as of June 1st, we had over 1,300 participants. And we're celebrating this year our 25th anniversary. We are also owned by an insurance plan, and this was an instrumental part of how we were able to respond in the manner we did. Next slide, please. So in the middle of March, there was a sense of urgency for our program to meet the needs of our participants given the pandemic. There were many COVID-19 related challenges. First, how were we going to meet the needs of our participants? How were we going to ensure that they did not feel abandoned if they could not come into the center? And I think you heard a lot of examples of things that we also did, so I won't go through that. But the promise of PACE to reliably adapt and to meet the needs of our participants was going to be tested in a way none of us could have imagined. We needed to prepare for a worst case scenario and for what we had been seeing. In fact, this scenario played out in Massachusetts in the middle of March. We saw widespread outbreaks in long-term care facilities and assisted living facilities. So all of our sites remained open in Massachusetts, but only half of them had a very small number of participants attending. And in fact, we had to adjust the way we deliver care, medical and social care. And I think, again, you heard a lot of examples, so I won't go through that. In addition, we had particular concern for our members living with dementia and those living in the assisted living facilities who might end up in the emergency department. This was our problem. There were limited options for COVID positive participants whose goals of care were to remain in the community. There were limited skilled nursing facilities taking admissions, and there was often lack of home care staff willing to come into the home for our COVID positive individuals. So who was best able to rise and meet the challenge? And the answer clearly was our own PACE team. So the decision was made to temporarily use our new flagship site as the Summit ElderCare Infirmary to provide around-the-clock support for our COVID positive participants in need. Besides the individuals we mentioned before, we were going to need to support individuals with goals of care that included avoiding going to the emergency room or hospital or nursing home, and wanted, again, to remain in the community. We also had to care for those participants that may be end of life with COVID-19. They were going to want to have their families be present for their final transition, and we needed to create protocols to allow this to happen. So in order for all this to occur in a very short time frame, our Fallon Health leaders helped us to get quick approval from the Executive Office of Health and Human Services and the Department of Public Health. We had to rapidly develop implementation and budget plans. And then lastly, we had to get approval and sign off from multiple stakeholders, both internal and external, state, local, as well as national. Next slide, please. All this resulted in our transforming one of our sites into this 22-bed skilled nursing care unit. It really took operational leadership, and we had leaders who stepped up. One of our site directors, Jennifer Maynard, who's a registered nurse, and a clinical nurse manager, Sandra Casares, was the first, they were the first to volunteer immediately to work through the necessary steps. But behind these leaders, we also had a guiding coalition of others, including the executive director, senior operation director, director of quality, senior VP of strategy, and myself working on a readiness and operations plan. We met daily, 7 days a week, sometimes twice a day, to make this plan become a reality. Our first focus was on readiness. We had to develop an operational plan, policies, procedures, for multiple areas, including infection control, employee monitoring, training, staffing, as well as nursing and medical management. Again, we're taking an office site, an adult day health center, and turning it overnight into a nursing home. We also had to identify staff who were going to cover the infirmary 24 hours a day. So the IDT had to be repurposed. Prior to starting, we arranged for COVID testing for all staff to make certain they were negative. We had to train and retrain people on the use of PPE, as well as making certain they were fully compliant with our infection control policies and other guidelines. And then the building had to be upgraded to meet the standards for a nursing care facility. So with all that going on, concurrently, we had to develop an operations plan. This involved extensive communications to all staff, our participants, their families, as well as to our partners, the assisted living, nursing homes, and hospitals. An admission process had to be available 24 hours a day, 7 days a week. Food for participants and staff, including special diets, had to be arranged. Medication delivery was needed at least 3 times a day, including palliative care kits. Therapy for those needing rehabilitation needed to be scheduled. An approach for family visits had to be developed and implemented that met public health standards. And then lastly, we had to prepare for people going back into the community and being discharged. Next slide. So it was very important for our leadership and our staff to show our participants, their families, and caregivers, as well as the referral centers, that we were making a difference in this time of great need and uncertainty. Our first COVID positive participant was diagnosed on April 2nd. We opened on April 22nd, approximately 2 weeks before the surge hit our regions. Our first participant was admitted the next day on April 23rd. And overall, we had 11 participants served. Remember I said we had 22 beds? This was much less than we expected and prepared for, but we were thankful that we did not have a worst case scenario here. Our longest stay was 23 days, shortest stay was 7 days, and the last participant was discharged from the infirmary on June 5th. This is a picture of our first participant to be discharged with her husband accompanying her. We had a big celebration for her and the other 7 participants who discharged back to the community. Unfortunately, 3 of our participants passed away, but their families were able to be present on site and be there with them for support. Next slide. So what were the lessons learned? We had always heard about PACE being uniquely able to do novel things, but this pandemic has really shown that we can transform in multiple ways to meet the needs of frail older adults. There are very few health systems that are able to come even close to giving what is needed in the time that was required. The social needs, the social supports, the social isolation that are problems we were able to figure out and manage. One of the senior executives from a large medical group who sits on our quality committee stated, "You no doubt saved lives." Innovations can give families hope and hospitals options, and this is what PACE affords. And I think what I would take away from this is that now more than ever, PACE should be available to all eligible older adults, especially those from minority and marginalized groups that we endeavor to help. This is the gold standard of care, when care is aligned with what matters most for the individual. And I think this was best illustrated by a note from a family member, which says it all. My parents are participants of the Summit program and residents of an assisted living facility. Knowing there was a place to care for them, should they become ill with the virus, gave us great comfort in a time of severe worry. After all they have been through, having to struggle in the hospital system with COVID would have been excruciating. Thank you for volunteering. Thank you for caring. Thank you for doing a difficult job. Thank you for being our heroes. I have shown how our PACE program has met the challenges so far, but this is only part of the story. What does PACE look like moving forward? And how will it continue to meet the ongoing challenge posed by COVID-19? How do we reopen and stay open given what's happening around the country? How much care stays in the community now? And how do we expand PACE into many of the marginalized communities around us where the need is greatest and where individuals can benefit the most? And lastly, how do we engage our participants to help us determine how best we can do this? So with that, I appreciate the opportunity to speak on this topic, and I will pass it back to Logan.
Thank you so much, Dr. Schreiber. As a reminder, if you have any questions for any of the speakers, please share them by clicking on the Q&A icon at the bottom of your screen. Shortly, we'll begin answering those questions, and we've received many great questions already. So thank you so much to those that have submitted them. Next, we will turn to Peter Fitzgerald, Executive Vice President for Policy and Strategy at the National PACE Association, who will reflect on some key policy implications and questions.
Thank you, Logan, and good afternoon, everyone. As we've seen PACE organizations respond to COVID-19, we're interested in considering the implications of the innovations that have been developed out of necessity, but we might want to retain as a virtue of the program moving forward. So I wanted to share with you some thoughts on those issues. Go to the next slide, please. One observation from these innovations is to underscore that it's really the PACE interdisciplinary team, not the physical site of the center itself, that integrates care. Throughout COVID-19, maintaining the interdisciplinary team members' communications with one another and with their participants has been a key to their ability to take care of those participants. And they've been able to build in those communications on the trusting, already well-established relationships that they have with one another, with the participant, and with the caregiver. I think throughout much of its history in PACE, the center has come to represent really some functions that are not necessarily inherently based on its brick and mortar. It's come to represent that interdisciplinary team, which is housed at the center. And it's also come to represent the provider capacity that PACE organizations bring to the care of their participants. Really what we've seen in these innovations is that both are essential and both can be deployed back into the community outside of the center. Notably, the PACE Center might be evolving to address new roles with regard to respite care, overnight care, and temporary shelter, as you just heard Dr. Schreiber describe. And the PACE Center's resources might evolve to be deployed more in the community and less at the center site itself. And in doing that deployment, one of the key features of PACE is that it is a provider, not just an insurer of care. And as a provider, it brings significant provider capacity to the care of the older adults that we serve. And that provider capacity during COVID-19 has been brought to people's homes to maintain their care, their physical care, to maintain their connection with staff and with fellow participants, and to maintain their communities through social media and other forms of communication. So I think one thing we look for moving forward in terms of what we've learned from COVID-19 is that we might want to reconsider the PACE Center's role in light of its function to provide provider capacity and to support the interdisciplinary team. We've also seen a significant increase in the role of telehealth for delivery of care, and that care delivery starts with effective assessment and care planning, and PACE organizations have been able to do that through telehealth, both audio and video telehealth, and in some cases, audio-only telehealth. Not surprisingly, given the population, low-income population that PACE organizations serve, there's often very limited access to video support for telehealth encounters, and so audio encounters become a significant part of what we need to do. And I think we also see the real value in expediting access to post-acute care through a PACE organization, means for diverting people from nursing homes or hospitals or emergency rooms where their risk of COVID-19 infection is greater. I could go to the next slide. Specifically with regard to PACE policy, we can see that it's likely that regulations and policies moving forward might need to reassess the PACE organization's capacity. We've relied on PACE organization square footage, PACE organization center locations as a means for determining that organization's capacity to care for participants. And through the innovations that we've seen in response to COVID-19, we may very well want to question and re-examine those assumptions. I think it will be important moving forward to retain the flexibility for telehealth that has been available to PACE organizations during COVID-19. And so again, reconsidering regulations that currently restrict or limit PACE organizations' ability to apply telehealth to their performance of assessments and to their care delivery. We've also seen with participants receiving more care at home and with their family members spending more time at home, an increased role in the care that's provided by family caregivers. While PACE organizations have always coordinated with and supported family caregivers, it's possible looking ahead that we might see an increased impact from participant-directed care that involves family caregivers and an increased role for family caregivers in implementation of the care plan. And that might be something to consider looking ahead. As I mentioned earlier, timely access to PACE during COVID-19 with the expanded options that the PACE Center might provide in terms of an alternative care location is really essential in order to divert people from those more high-risk settings. And yet currently with PACE, there can often be a significant lag in eligibility determinations and in enrollments. Specifically, PACE organizations are not allowed to begin enrollments until the first of each month. And when you're trying to effect a hospital discharge into a PACE center or PACE organization, an individual and their families may not be able to wait that long. So it will be important to look at how we can expedite access to PACE moving forward. And I think it's also instructive to us what we've seen with regard to the repurposing of the PACE Center and an increased focus on delivering care in the home and in the community opens up the PACE model of care for new populations. Several years ago, Congress passed the PACE Innovation Act, authorizing the Centers for Medicare and Medicaid Services to implement PACE pilots for individuals under the age of 55 and individuals who are not yet nursing home level of care, but may be at risk of that. And in talking to stakeholders in both of these groups, one of the concerns that has been raised is that the PACE care model relies significantly on congregating individuals in PACE centers, and particularly for younger populations, people with disabilities, that is not their preferred location of care. And what we've seen through the adaptations to COVID-19 is that PACE organizations may very well be able to meet the needs of these new populations without as much of a reliance on the PACE center. So thank you for listening to these thoughts and observations. And I know, speaking on behalf of PACE organizations nationally, we very much look forward to working with policymakers and our fellow providers to increase access to the program.
Great, thank you so much, Peter. Our final speaker before the Q&A will be Ann Tomlinson. Ann is the CEO at ATI Advisory and an expert in long-term care financing and delivery, as well as integrated care models for older adults.
Thank you. So I'm going to be really brief because I know there are lives watching all the questions piling up in the Q&A queue, and I want to make sure we have a chance to get to at least some of them. So I want to say two things. We are at this. So first of all, thank you for inviting me to speak, and it's really inspiring to listen to the way in which the PACE organizations who have presented here today have really risen to the challenge of the moment. And it is a rare moment. Everybody knows that. It is obvious, but it is a really, it's kind of a, once in a century opportunity to rethink, pretty much everything that we do across every single institutional, institution in our society. And, health and long-term care are no exception to that. So I think that I would say that never before have we so needed community-based, flexible alternatives to nursing home care for populations that have that level of need. Sort of never before. And I think that the experiences of PACE organizations throughout this pandemic have really demonstrated the, in a way we would never have had an opportunity to demonstrate before what PACE organizations are actually really capable of. And it almost kind of expanding how we even think about what defines a PACE program, because I think in many policymaker minds, it has been, as Peter was saying before, it's been like everybody sort of thinks, you think PACE, you think adult daycare center, and that's really, I think what you all have demonstrated is that that's not at all the defining characteristic by any stretch. So so here we are at this moment in time that has created these incredible imperatives. One is for alternatives to institutional care. Going forward, access to nursing homes is going to be dramatically reduced, even if, and obviously the public health imperative to keep people out of nursing homes is even greater. But nursing homes all over the country are in the most challenging financial situation that they've ever been in, and many of them won't survive. So what are we going to do with people who have this level of need? We've got to really ramp up our ability to serve them. Two is that the imperative is for the flexibility and the ability to deploy healthcare dollars differently. We can't do that through fee-for-service. There's nobody managing that pot of dollars, and they're not flexible. We've got to be able to keep people at home, reduce social isolation, and address engagement and provide engagement and meet medical needs remotely. We're going to have to do that for a long time. That's going to be our mandate and our imperative for the foreseeable future for this population. So by definition, what that means is that we really have to be able to evaluate individual needs, access resources on their behalf, manage this complex array of services, and coordinate it for the sake of efficiency and outcomes. All of that can only be done in a really flexible platform like PACE. And finally, I think one thing that we realize is going forward, certainly more than ever, where you live really matters. Where you live geographically and the situation in which you live. And as such, community matters, the community you have around you and the community that you participate in. So all of those things, we have to build strong communities that address the care needs of their populations going forward. So alternatives to institutional care, maximum flexibility to address individual need and the ability to do so, deploying different people into different roles, using funds differently, and then building community. All of those things, every single stakeholder on this call, whether you're a healthcare delivery system, a policymaker, state, federal government, Medicare Advantage plan, PACE organization, those are the things that we have to be laser focused on. And so maybe I'll just sort of conclude by saying that the implications of what we have been able to observe PACE organizations doing during this pandemic with their care model, with their teams, with their resources and assets and their know-how and everything that they bring to the table. I think we have learned that provider-led risk models must be fostered going forward. And that includes PACE, but it's also broader than PACE, direct contracting, value-based contracting within Medicare Advantage. That is, moving risk down to the provider within a Medicare Advantage contract and fostering integrated care for dual eligibles in a provider-led risk-based model. And that states, the federal government, really, really have a mandate right now to think strategically about how to broaden their reach of PACE. I just want to say, at the same time, PACE organizations have got to start to think more strategically as well about how they are going to broaden the portfolio of solutions that they offer and the price points at which they offer them. Meaning, how can we organize the different types of services that and interventions and things that you deliver within different types of risk-based products that Medicare and Medicaid offer. So that's my request of you all. And I would say, I think that, maybe kind of the final two things is that, for states and the federal government and policymakers, the notion that we have this money available to people for room and board only when they're in a nursing home has met its time's over. People need to be able to access a variety of different housing arrangements with the Medicaid dollars when appropriate, and there has to be a risk-bearing entity that is an entity that can manage those funds in charge of that and helping to manage that. And then finally, I would just say, I think this has really, for PACE organizations, for any risk-based organization, primary care clinic model has really given us an opportunity to rethink the costs of delivering these services. We know now that we have to have a flexible workforce, that when we do, they can be deployed very, very efficiently across a number of different domains and roles, and that it's possible to leverage technology to do things we thought could only be done in person before, and this opens up a world of opportunities. So I really appreciate the opportunity to share just some initial thoughts and a little bit of context with you all for everything that you've heard today, and I'll look forward to hearing the Q&A.
Great, thank you so much, Anne. Now we will begin the question and answer portion of the webinar. We received a lot of great questions already. We'll do our best to answer as many as we can. And with that, I'll dig right in on a question that we received. And I'll invite all of the panelists to share their video now. And this question asks and I'll invite the PACE organizational leaders to speak to this. So Samantha, Marianne, Dr. Schreiber, if you'd like to, any of you would like to answer this first. Can you speak about individuals with serious mental illness and how the PACE program addresses their mental, cognitive, and physical needs?
The majority of our 55 to 65-year-old group, and I think this is true for most PACE organizations, you tend to see more of concentration of folks with mental health as their primary issue, or one of their primary issues in that age group. I think PACE is really uniquely situated to be able to support them, and even especially during the during COVID, just because of the intensive outreach, because we're very aware of their diagnosis, their depression, their anxiety, how we closely assess them and kind of keep track of how their coping is going. But with the high touch of the frequent contacts, but also they tend to be the more technologically savvy of our entire population. And so these are the folks who can easily jump on a Zoom call with us. And we do a lot of, all of our counseling right now is one-to-one by Zoom. And these folks easily get on their smartphones, or they get on their own tablets, or they're using one of ours. And we're able to access them and support them in ways that even some of our local mental health centers and counselors aren't able to. So that's my response, Bob, or Rob, I'm sorry.
Yeah. So I'll just add to Sam. So a lot of the same things. We have about 60% of our population that has serious mental illness. Mm-hmm. And so we have tried to integrate working with licensed mental health counselors, developing care plans that are specific. We, again, also have a large younger population, many of them that have this behavioral health concern. So how we integrate that in the COVID pandemic has really been the outreach through telehealth. Again, doing a lot of counseling group sessions, really meeting people where they're at, and trying to, again, have the entire interdisciplinary team check in with them. So somebody will call every day, every other day, it just depends on what that individual needs. But it's really customizing the plan of care with these individuals' needs. I wouldn't say it's working out dramatically well, but it's a lot better than what we had feared it would be. And people are actually developing novel approaches and novel ways of dealing with the, forced isolation.
Great, thank you. So next, we received a number of questions about the financial model of PACE. And one question asked, with PACE programs taking on full risk for members, how do these programs stay financially viable? So I'll invite Peter, Mia, or Chris, if you'd like to tackle this one first. Oh, and Peter, I think you're muted.
Yeah, I'll say a little bit about it, but I actually think the management of those financial resources occurs at the PACE organization. So maybe one of our panelists can address it. But I think it's key to being able to manage the risk is combination of Medicare and Medicaid resources and pooling those capitated funds, which allows the PACE organizations to deploy resources most cost effectively and address those social determinants of health that can lead to much more expensive care needs if they're not addressed, address preventive care that can lead to acute care if it's not provided. So I'd say the general answer is integrating the financing across the two programs, the Medicare and the Medicaid, which correspondingly integrates the care across long-term services and supports and medical care and primary and preventive care. Those are essential to the financial part of the program working and the care model part of the program working. Ask maybe one of the PACE organizations to elaborate on that.
This is Marianne. Hi. So we've been around only 12 years. I've been the director during that time. And I have to say, when we focus on the need of the patient, not the finances, not the bottom line, the dollars work. So you focus on quality, you focus on what's the right care for the patient at that time, what is needed, the dollars work. It's amazing. So, I mean, of course, as monitoring this program, you have to be financially viable, but part of the regulations require us to maintain reserves. That we will have high costs. We care for a incredibly frail, complicated population. And this is, some of the highest cost in Medicare is what we see, right? This is end-of-life care in many cases. Navigating that care based on what the participants' wishes are, what do they want their final years to look like? and following their lead. If we're true to that, the dollars follow. It's really remarkable, and it's really an honor to be part of such a program.
This is Rob Schreiber. I just want to add two things. One is totally concur with what Marianne said. 70% of outcomes, health outcomes, are driven by social determinants of health and health behaviors. What the issue oftentimes is in total risk, you take a medical model and you don't have that social determinants of health support, you're going to lose your shirt every time. That's first thing. The second thing, I have to emphasize this again and again. What matters most to the individual? By focusing what truly matters to the individual, giving them full information, they can make the best case of what they want and what they don't want, how they want to live and how they don't want to live. And if you focus on that, it works out, assuming you're billing and doing all the things you have to do in terms of running the business, but it does work. And that is, I think, the secret sauce.
Great, thank you. And then we received a few questions related to how the PACE model of care during COVID is different than home care, or is it the same?
I'll start with that, but my colleagues, I'm sure, will add more. But home care is such an essential ingredient in one's care, in one's health care. It's an important ingredient. What PACE offers is the whole wraparound. So PACE is driven by this interdisciplinary team that's looking very holistically at the patient's needs. And that's their needs in their home, but it's also their other needs, their medications, their DME, their home safety, it's their specialty care, it's their primary care, it's their level of function, how their long-term trajectory, what are they looking at, what are they wanting, and what do we need to put in place to honor that? So it's really the very comprehensive coordinated model of which home care is a critical piece, I would say. Can others help out?
I think that whole, the whole socialization piece too, it's all of the intensely coordinated care, but then that sense of community, especially in a very isolated setting, that we can uniquely do that I think is just, it's a little bit more than what just sort of standard home health or home care looks like. And that's such an important part of, you know, as both of you have said, that kind of drives everything. If we're addressing the social determinants of health, the rest is possible. But yeah, that's where it feels different to me.
Can I just jump in here and just say also, I mean, this is what part of what I was trying to communicate was that, you know, to the extent that there's this perception that PACE is, it's, sort of support for people with long-term care needs in an adult daycare or congregate types, day setting. It's really, this is, I think if anything were to sort of illuminate the extent to which PACE is a completely holistic, all-inclusive, just like the name says, care delivery system, that it really is agnostic to where that person is, in time and space. This has been the opportunity to really demonstrate that, and it's been so pleasantly surprising to me. Not surprising really, but I guess, mind shifting, consciousness shifting a little bit around what is really possible with this model.
Thank you so much. Unfortunately, we are running out of time. We weren't able to answer all of the questions that we received, but I'll let everyone know that we will be sending out an email that will have a link to the slides, a recording of the presentation, and feel free to also be in touch with any questions. I'll also share that for those of you who may not be familiar with the Better Care Playbook, we welcome content submissions on evidence-based and promising practices in complex care. And again, our website is bettercareplaybook.org. Next slide. And finally, we'll just ask to please fill out the evaluation survey. It will show up on your screen after this concludes. We've shared it in the chat feature, and we'll also again send out a follow-up email after this. We really value your feedback, and it helps us publish content on the playbook that addresses the needs that you have. And I just want to close today by thanking all of our presenters, who shared great insights with us today, to the 7 Foundation Collaborative and the West Health Policy Center for making this webinar possible, and for everyone who joined us on the webinar today and shared your wonderful questions. Thank you so much, and have a good day.